Hello, my name is Narissa Bauer, and I want to share our study entitled Acceptability of Group Visits for ADHD in Pediatric Clinics. Attention Deficit Hyperactivity Disorder, or ADHD, is common. It can affect how children do at home and school, affects family cohesion, and can lead to long-term problems like risk-taking behavior, substance abuse, academic issues, and lower self-esteem. Pediatric providers must be able to identify ADHD from other conditions like anxiety or learning disorders. The problem remains that clinic visits are often limited to 15 to 20 minutes, not a lot of time. If you are a caregiver of a child with ADHD, think about the last time you were seeing your child's provider. Did you have enough time to ask your questions or share your concerns? And if you are a provider, have you ever wished you had a different way of providing support? This study focuses on the perspectives of caregivers, children, and providers towards an innovative ADHD group visit model and curriculum that we fondly refer to as the TEACH program. TEACH stands for Tailoring Education for ADHD and Children's Health. Before we get to the findings, I want to give you some background. TEACH is a family-level intervention designed so that primary care providers can address unmet healthcare needs of families struggling with ADHD. The curriculum is for families, is delivered over 5 sessions at quarterly intervals, and the best part? It takes place in the clinic where families are used to going for their care. 2 trained facilitators who are members of the clinical team lead each session. The ideal group appointment has 6 to 8 families coming together in separate spaces for caregivers and children. We feel that TEACH helps providers do what they love to do the best, which is to take care of their patients by giving them the extra time to go in depth about ADHD, sharing knowledge, and helping families learn skills so that they can manage their ADHD better. Families in the program learn about an ADHD care plan. Each session covers a part of treatments so that by the end, families have a completed care plan. Families and the facilitator spend approximately 45 to 60 minutes in active discussion. And at the end, providers do a quick medication check while the families complete an activity together. The goal is to ultimately increase caregiver and child confidence in their knowledge and skills around ADHD care. In this study, we analyzed data from school-aged children caregivers and facilitators who participated in one of 2 randomized trials of our program between 2012 and 2015. A total of 34 caregivers, 41 children, and 9 facilitators offered feedback. Some of the important themes that emerged of the program included the following. Caregivers enjoyed the support group atmosphere and learning new things from others in the group. Others shared stories of an improved understanding of what ADHD is and what it is not, as well as alternate ways to handle common parenting issues or concerns. These stories were valuable for the group to understand that everyone experiences good and bad days, and that some of the challenges were more common than believed. Caregivers eagerly listened to new ways to handle things at home, at school, or with providers. And when we asked children to share their thoughts, many were able to recall specific things they learned. Children reported realizing that there were other kids out there like me. One unforeseen benefit of the group was that caregivers reported more talking with their child, especially after group appointments, and that it was easier to talk with them. Some of the advantages of the group visits for providers were the obvious. It gave them more time to go deeper into topics and provided a way for them to get to really know their families, including the unique challenges and concerns they faced each day. Providers had a growing appreciation of just how hard these families kept trying against all odds to help their child succeed or get services. Providers also felt it was helpful having kids in the group with others as it gave them an opportunity to observe peer interactions. We learned that families prefer these types of appointments during after-school hours, and because of timing, providers were able to witness medication wear-off. And while the challenges of the program include needing to have physical space to hold the group appointments, scheduling, and advanced planning with the clinic prior to implementation, providers felt that the benefits outweighed the challenges. It even gave some a renewed sense of satisfaction, and one provider even went so far as to talk about how it was a way to prevent burnout. To summarize, key findings was that we found that group visits were acceptable to all stakeholders. Acceptability and satisfaction are important considerations when thinking about new systems-level solutions to address common issues in primary care, just as much as the effectiveness of the intervention. As for future directions, we plan to conduct another study to scale up the intervention, as well as to bring in technology to help support families in between group sessions. Other areas of research include studying implementation strategies to facilitate adoption of this program in other settings. We invite you to read the full manuscript, which is published by the Journal of Developmental and Behavioral Pediatrics.